Yeah. Good morning, friends, all those who are in India, and good evening to all my friends in the United States of America. And welcome again to this weekly webinars that we are having for the last 80 weeks. And today is the 80th of the series of webinars that we are conducting on behalf of Andhra Medical College. And I'm very glad that we have a very important persons on board. And we have Dr. Sridhar Chilumuri himself, who is going to moderate this session after introducing Dr. Frankie. And Dr. Ram Kairam is already on board, and I'm sure he'll be contributing towards the end. And all the friends made it possible to have completed 80 such webinars. I'm sure we are going to have many more to come. And as we keep on discussing various aspects of COVID-19, newer challenges are cropping up. So like reinfections, as well as breakthrough infections. So we have a very illustrious speaker today, Dr. Franklin, who will be talking about COVID-19 and rheumatic diseases. And Dr. Chilumuri will be introducing him, and we will know his expertise. And I'm sure he'll be answering all our questions towards the end of this particular session. Over to you, Dr. Sridhar.
Thank you. Today it's kind of a special privilege for me to introduce my colleague and friend Giovanni. Giovanni Franklin belongs to a rare breed of physicians that you will never come across. He's a full-time clinician. He's a scientist as well as a medical educator, which is very, very rare combination to have three buckets going at the same time. So Giovanni came to us first having done his medical school in Brazil. Followed by that, he had a master's degree in immunology and parasitology in Brazil. Later on, did a PhD at the Becower Graduate School of Molecular Medicine in Manhasset, New York. Followed by a residency at the Albert Einstein College of Medicine, a fellowship in rheumatology at Albert Einstein College of Medicine, and later on another fellowship in Columbia University. He's also one of the scientists at the Feinstein Institute of Molecular Medicine. He has been a recipient of NIH grants, and his research has a very wide spectrum. He's worked on trypanosoma, later on HIV, and then moved to immunology, particularly lupus. And he's one of the premier researchers in lupus. And we are very lucky to have him here at our institution, where he's the chief of rheumatology. And as I said, he's also a medical educator. He's also a program director in medicine. Right from the very beginning, as we were faced in March with a brand new disease, we were very eager to get some of the sharpest brains in our think tank that we would develop protocols and guide us on how to manage the patient with this new disease, which we think is primarily immune mediated. And we were lucky to have Giovanni working with us, and he was one of our lead team who developed protocols and guided us on how to manage COVID at a time where hardly anything was known. He has published in this field, and he's going to also share his expertise in how to manage COVID and how it behaves with various rheumatological illnesses. I could go on, but we need time. So Giovanni, why don't you get started, and at the end we'll take questions.
Okay, so thank you very much. That was an amazing, kind introduction. And I want to remind you all that sometimes, so as Dr. Chilumuri says, that it's very difficult to have clinicians trying to do all different things. It really depends on mentors and people that will help you to try to achieve these kind of things. So if it wasn't for Sridhar, I would not be able to do these things, and and he was the one who actually motivated me and trying to continue doing research and getting me involved into education and residents and students. And so you really need to have an environment and a person with vision that are able to do that. And also the credit for all the protocols for COVID was, of course, not all mine and really minimal mine. And I think that, you know, the vision also from Sridhar was just to get everybody and key people from pulmonology, from nephrology, hematology, all get involved and work together in trying to come up with the protocol that we were developing. And also creating a space for us to do some research at the time that I will just mention at the end a couple of things. So just to get started, so I really, it's commendable that there are this many people here at 6:30 in the morning in India. So very impressive. But so I think I was told to work with perhaps 25 minutes or so, and I have too many slides here. So for some of them, I'll go quickly. And the idea was really to give a general overview on how where we approach in rheumatology, because at some point when March hit and all our clinics were practically closed, you know, you can imagine that 95% of our, the bulk of our care is really outpatient clinics. So we were kind of like lost in what's going to happen with our patients. First, how are we going to get them medications? The second is what's going to happen if they get COVID, because now we were dealing with, you know, immunosuppressive patients where it's just based on their primary disease, or if it's part of their immunosuppressive therapy as well. So these were all questions that we had, and that even though the concentration of the thought at the time was for patients getting admitted to the hospital and the mortality was really high and what we do, you know, in the back of our mind was what's going to happen with our patients. Are they at a higher risk for disease progression or mortality? So a number of people, so that's when that was developed. And I will just briefly mention that data from the COVID-19 Global Rheumatology Alliance that was developed beginning in March. And so these were registries, and I'll mention about the current numbers, the case control studies, and also what's happening with the mRNA vaccine response rate. And also, are we observing flare rates with vaccines? And so if we have time, I'll also mention a little bit about the use of anti-rheumatic medications. So there was an explosion of approaches in the treatment of COVID using anti-rheumatic medications, and everyone now is more familiar with our biologics, our synthetic DMARDs, and so that's also was very interesting. And so the creation of this global research alliance for rheumatology was really happened on March 11. There was a Twitter call out, and many members, including patient representatives, several countries were part of this, and they started this registry. So at that point, within a few months, there were more than 3,000 cases registered, and with a patient survey of more than 12,000 entries. And also as a role for this alliance was to review the anti-rheumatic drugs used for treatment of COVID, and also another unintended consequence, and especially at the beginning with the advent, you know, the idea of Plaquenil implementation in treatment, and the whole world practically were rushing to get Plaquenil. So it all, of course, the shelves were empty, and our patients that had been on Plaquenil required for disease maintenance, they all were not able to get it. So what happened with this? So that was primarily the focus of this alliance when developed at that time. So as of now, there has been 26 papers that were published, and the early publications really that I'm talking at first will encompass about 600 patients, and that's from 4 different countries. Currently, the total registry has about more than 15,000 entries, 7,000 more in the US, in Europe more than 8,000, and with patient survey including more than 14,000 entries. So for for these earlier studies, so I mentioned as the total of 600 patients, again, the majority of our patients are female, so more than 70%, and that represents really the demographics of our autoimmune patients, and with a median age of 56 years. So about half of these patients were hospitalized and about a 9% mortality, which was kind of similar to what you're looking at the general population. Even though this number in some cases goes to 20% or more during the high number of admissions that we had between March and May. So the diagnosis represented here, the most common one is rheumatoid arthritis, followed by lupus and psoriatic arthritis. And so some of the less common. So it's interesting to note here that gout may represent a much larger number in terms of incidence. So when we look at the incidence of rheumatoid arthritis, it's about a 0.5% in the US. And gout, it really has increased the incidence of gout in the last 20 to 30 years, more than doubled what it was in the 70s. And so we are now close to 4% of incidence. So what was interested in, I will mention the idea of how to approach this and tease those numbers is, why is it that we have so many more patients with gout, but they are much less represented? So what's happening in gout that could explain why we had a lower number of patients that were contracting symptomatic COVID? So I'll mention that later. So this, we are looking at the odds of hospitalization for patients with COVID. And so just to remind you that here, all the patients were from rheumatological disease patients. So we don't have a control here. So rheumatoid arthritis was arbitrarily chosen as the 0 point and then calculated based on all the other rheumatological diagnoses. So we see that there isn't really much of a difference in terms of psoriatic arthritis, spondyloarthropathies, or vasculitis, with a trend of perhaps lupus having a higher risk for hospitalization. Just a question, are you able to see my arrow? Because I keep pointing, but I don't know if you see my arrow when I'm pointing to things on the slides.
We can see your arrow.
Oh, okay, thanks.
Yeah.
So, so then looking at the odds for hospitalization in these patients, so the risk for hospitalization is what you are very familiar with, what has been reported many times of comorbidities, including diabetes, renal disease, hypertension or cardiovascular disease, and chronic lung disease. And so these risks primarily were higher than other rheumatological diagnoses. Now, when we look at medications used in these patients, are there any medications that pop out as increasing your risk for hospitalization? So there were none. And as a matter of fact, if you look at anti-TNF, this seemed to be actually protective in terms of hospitalization. Now, so C-acid DMARD is just the traditional synthetic DMARD, so it includes methotrexate, sulfasalazine, leflunomide. So hydroxychloroquine is listed here as well with as not an increased risk. And so again, I don't know if we're going to have time to talk about hydroxychloroquine, but early on we were trying to see, because of the earlier papers suggesting that hydroxychloroquine had a positive effect on preventing disease progression, we were hoping to see that we might see that signal in our patients. So even though we were not seeing that rheumatological patients were protected, and especially the ones that were on hydroxychloroquine, which can be represented here by this number as well. So another angle of seeing how hydroxychloroquine may not necessarily be, that helpful from some of the earlier studies. So corticosteroids are not listed here. We'll talk about it later. But so also the biologics, non-steroidals, and if you're only having biological DMARDs or the targeted DMARDs. So targeted DMARDs include the JAK inhibitors. So not a lot of, no effect of drug therapy in terms of hospitalization. The odds of hospitalization with prednisone here gets a separate slide, and so that they divided with a lower dose of prednisone, less than 10 milligrams, and more than 10 milligrams. So they did not see any effect of lower dose prednisone increasing odds for hospitalization, but there is if you look at doses of more than 10 milligrams. And this was shown for other studies as well, not just for rheumatological patients, looking at chronic use of steroids. So higher chronic use of prednisone may not be a good thing if a patient gets COVID. So now looking at risk factors for death in COVID patients, and now here they increase. So this data was looking at a higher number of patients. It went over for a longer period of time, and so this was published early in 2021. And so includes about 3,700 patients. Again, similar demographics that I mentioned before. Also, the mortality here is about similar to what it was in the earlier stage of the studies. Not much difference in terms of what kind of rheumatological diagnosis we're dealing with and represented. So from now on, the analysis that they're going to show for all patients. And then they separate into groups for just rheumatoid arthritis, inflammatory arthritis, or vasculitis and other connective tissue disease. And so here, so remember again, we're looking at mortality, and the colors represent what I just mentioned for all patients: inflammatory arthritis in red, yellow rheumatoid arthritis, and blue all other connective tissue disease. So when we look at age, again, the mortality is higher on over 75-year-old compared to 66 to 75. And being a man increase your risk also, as we know. So also for rheumatological patients, smoking has a slight effect. And we really don't see much of a difference between the different subgroups of rheumatological diseases, as you can see here. Now, also, what's important to note is that patients that have currently moderate to high disease activity, they are also at an increased risk for mortality. And this is important also when we look later as the effect of prednisone, which they were able to tease a little bit of difference between is prednisone alone a risk factor, or that's kind of masked by the disease activity. So moving on, other risks for mortality, as we mentioned before. So hypertension alone or cardiovascular disease, in this case, did not seem to be much of an effect in mortality, but the combination of both was. Lung disease also present here with renal and diabetes, not as high as we have seen in other non-rheumatological studies. Now, looking at each disease individually, again, maybe a slight trend for lupus, having a worse odds ratio for mortality, and none of the other separate groups here were represented. So just to note here that rheumatoid arthritis is not listed in here, because remember, they were using rheumatoid arthritis as their case control, since all patients here have a rheumatological disease. But I'll show some data that suggests that rheumatoid arthritis may have a worse prognosis. So we are all, so there is a flaw in this analysis here, because we don't really have a control group here. So we're looking at all just rheumatological cases. And so when you compare everything else to RA, you're not seeing really any significant increased odds of mortality here. But RA could be at a little bit of a higher risk, right? And so we'll see that later. So now, when we look at all medications here in this group as well with mortality, so again, for all the different groups, and we have all different immunosuppressants, and they really don't seem to increase much of a risk of mortality. And look at TNF inhibitors here, almost having like a little bit of a negative signal, but the standard deviation is so wide for a lot of these things that doesn't really make it that much significant. But I just want to bring your attention, and also here, if a patient is in no DMARD, they already have, as an all patient group, a little higher risk so the DMARDs added to it doesn't seem to be increasing your risk for mortality, except for rituximab. So when you look here, you see a much stronger signal for mortality with rituximab. And so also sulfasalazine, curiously, seemed to have, but the numbers of patients on sulfasalazine was not too large, and you can see as well that the standard deviation is very wide here. But nevertheless, it is interesting because we usually tend to consider sulfasalazine as a milder form of immunosuppressant, and I certainly think of it less than leflunomide or methotrexate. But in this case, it seems to be giving somewhat a little higher signal. But I think that the most impressive here would be for rituximab. Corticosteroids did not have a significant impact on mortality. Now, this is what I briefly mentioned before, the effect of steroids. And in this analysis, they separated between groups of low disease activity here in the blue area, and the orange to red, it's patients with moderate to high disease activity. So with prednisone in the low disease activity group, even when you look at the higher than 10 milligram of prednisone, they didn't really have an increase in mortality here.
We can't hear you, Franklin.
They see a similar risk of mortality. And so I thought that this data was interesting because at first we were just thinking that prednisone alone is a risk, but I think that it's kind of masked by the disease activity. So patients who start with a higher disease activity are already at a higher risk. And those are the patients that are usually requiring higher dose of steroids as well. So it's something to watch for in terms of disease activity and being at risk for mortality. So in summary, I think that I think this shows evidence that really the other comorbidity factors that you're all familiar with seem to be more important than the particular rheumatological diagnosis. And these drugs also, they don't seem to have as much of an effect, except for, I would watch for rituximab. And also high disease activity, like I mentioned, it seems to be a higher risk for disease progression and severity. And so what I mentioned about the prednisone, there's still some work that needs to be done to really separate for us the difference of prednisone alone as a risk factor. So this is what I also mentioned earlier, and when we were looking, so this was a very, it's a comprehensive study in terms of an amazing number of patients. So in the UK with the NHS, they have access to so many patients and data. So this included a review of more than 23 million patients, and they end up with 17,000 patients that died from COVID, and so that they're looking at all the risks associated. And so all the way down here, you'll see that rheumatoid arthritis, lupus, or psoriasis, they do have a slight increase in your risk for death. However, look at all the other higher risks. So age, as we know, will give you a much higher risk. So being a man gives you a higher risk than just looking at rheumatoid arthritis by itself. And then we see all the other risks, and in many of our patients that have these risks combined, so it adds even more. So as we know, obesity, so is smoking, and ethnicity. We know that all races except, besides Caucasians that are at a higher risk for disease severity. And also interestingly, like they look at zip code, or it's a calculation that in the UK is applied to as a measure of poverty index. And so the higher your risk of poverty, the higher, and it's similar to what we have seen in the Bronx compared to Manhattan, for example. So again, so I think that this reminds us that yes, rheumatoid arthritis and some of the other rheumatological diseases have a risk, but it does seem to be small when we look at other comorbidities. So now we're going to show some of the US data. So these were from earlier in the pandemic. The next 3 slides is dealing with data from Boston. So when they look as well as risk of rheumatological disease in COVID, so there was no risk when they adjust for age. And this is a smaller number of cases, as you can see, 52 cases and 104 controls. And after adjusted, there was no higher risk for hospitalization or death in these patients. And perhaps there was a little higher risk on mechanical ventilation. And that was also unadjusted or after adjusting the data. But this was not reproduced in a larger cohort, also from Boston. They did not see an increase in mechanical ventilation, and as well for hospitalization or death or ICU admission. And then when looking at a more widespread US data, so here they had more than 2,000 cases of rheumatological patients. And after adjusting for all the other comorbid risks, there was also no higher risk for hospitalization or death. And so these are all very reassuring data. And again, after in this other study here, following 30 days after patients were admitted, so looking at they had it's a very complicated table. I'm sorry about it, but it's just that this is it's way they are weighted and they're matched to comorbid risks, and they do different. And when they do this extended exposure, because you do see some numbers here when they are not correcting for it, it seems to be significant. However, nothing is significant in terms of comparing of risk of underlying rheumatological disease and death with all these other items looking here for hospitalization, ICU, mechanical ventilation. The only thing that seemed to show some signal here was thromboembolic disease. Okay, so moving on to vaccination. A big question was now, how are our patients going to respond to COVID vaccine? We don't really have real data now. We have some. So what happened is the American College of Rheumatology put some guidelines for vaccination, and this was based on general consensus and perhaps some data that we have based for obtained for immunization for influenza or for pneumococcal vaccine, but nothing really based on COVID. So what they said is, in general, for a lot of our DMARD therapy, except for methotrexate, you do not have to do any change. Patients can just continue on them. Surprisingly, we tend to think that cyclophosphamide, it's a more potent immunosuppressive, but you don't really need to change if they're on oral cyclophosphamide. Anti-TNF, the biologics, including TNF, anti-IL-6, IL-1, 17, 12, and 23, belimumab, and either steroids, you do not do any change. They can just get the vaccine and no change in that. Now, for the methotrexate, they recommend holding it 1 week after each dose of the vaccine. For JAK inhibitors, also hold for 1 week. And for abatacept is one of the unusual ones that they recommend holding 1 week before and 1 week after. And IV cyclophosphamide 1 week after the dose, and rituximab to give about 4 weeks before you're going to actually do your rituximab infusion. So it's hard when you have patients coming in with a major flare that they haven't had the vaccine and they need rituximab because you don't have that time window. So in those cases, these are recommendations by the ACR, but it doesn't mean that we can't give the vaccine if they receive rituximab. But I'll show you the data, what happens when they look at some of that. So for this is the backbone information of what they based on to make those recommendations. And you see that they're really looking at just the flu vaccine, the pneumococcal vaccine, and in some cases here, zoster or recombinant zoster, Hep B, and HPV. Now, the ones outlined here in red is showing that really these are different studies here that you see listed on top. And for methotrexate, it was seen that there was a decreased response for almost everything that was looked at here. Now for TNF, there was no effect. And abatacept, in one of the studies showed some decreased response to pneumococcal 713. JAK inhibitor, one study also showed some decrease for the pneumococcal 23. And rituximab, it was decreased across for all the studies that's seen. And so this really it shows how they based their recommendations was really based on these studies and not based on COVID data. So this is just to show for this study, they actually looked at rheumatological patients that were receiving methotrexate and getting the flu vaccine. And they were holding the methotrexate for 2 weeks and then measuring their antibody titers. And so really the response measured here, so the white bars is they continued the methotrexate as opposed to the gray bars where they held it for 2 weeks. And the responders here is looking really at, in this case, for the optimal response to 2 antigens out of 4. And then here they break down into 1 out of 4. So the higher number of antibodies that you have, the stronger your response is. You're recognizing more antigens. So ideally, you want it to have it as all the antigens recognized, but you know that's not as good of, you don't see as many responders in this case. So we're measuring what % of patients receiving this immunization are achieving this 1 antigen out of 4 or 3 or 4 or 2. So basically it was significant when you compare the 2 groups, and after holding the methotrexate, a larger number of patients achieve this this response compared to the patients when you do not hold the methotrexate. So again, giving here some evidence to and rationale and why it would be a good idea to hold the methotrexate. Although ACR is recommending 1 week, and here they were holding it for 2 weeks. Another consideration that they're not bringing it up here is the risk of flare. And so I think that I talked to different, other rheumatologists and what was their approach. And my concern was patients that would be flaring. So we just talked about before how disease severity is a higher risk than even medication-wise in terms of risk for disease progression or death. And now when we are stopping methotrexate for a week or 2, many patients actually do flare. And so that if they flare, so you're going to have a higher disease activity. Now they are at a higher risk for disease. So I'm not so sure that, we don't understand at this point if the amount, even though you can see that it's significant, all these comparisons here, but how much of this is clinically relevant? So if you do achieve this amount of response, even if you continue all your medications, is that really going to be that much clinically significant for the patient? We don't know. So this is one of the early studies that they are looking actually at the antibody titer after COVID vaccine, and these are to the mRNA, so either Pfizer or Moderna, and they look about 2 weeks after the second dose of the vaccine. So we do have a control group here, and then patients in each of these groups here, either on TNF inhibitors, JAK inhibitors. This is the rituximab, so the B-cell depleting therapy, anti-integrin, and IL-12 and 23. So this is including patients with inflammatory bowel disease, because we really don't use anti-integrin for our rheumatological patients. So as mentioned before, anti-TNF really doesn't have a significant effect on the response. And here you have a very mild, it's not statistically significant. Now, the comparison between controls and the other, especially for JAK inhibitors, and rituximab is much higher. And there is really, it's not significant for integrin or anti-IL-12 and 23. So what I did mention here is that they also include patients that, in addition to these medications listed here, they might be on, in addition to that, on methotrexate or methotrexate and prednisone or prednisone alone, which you can see here. So, but they're much lower numbers than the general population included in each group. And so what impact does prednisone have on the antibody response? And so when we look at whether no prednisone or prednisone, and they're looking at both antibody titer, so antibody to the spike protein, or neutralization assay. And on both cases, and here for the prednisone, there is a significant decrease in the antibody to the spike protein or in the neutralization assay. And so we do not have here a breakdown of the dose of prednisone, but many of these patients were on a lower dose of corticosteroids. This is a question that we don't have so it's important here for patients receiving zoster vaccine. So these were 403 patients, including the majority here had rheumatoid arthritis and some with other rheumatological disease. And how many flares were observed in patients receiving the recombinant zoster vaccine? So we have been using the recombinant zoster vaccine for a shorter period of time, and now it's recommended for all our patients. And just the takeaway from this study here is that there was not a significant number of flares reported. So you know how some vaccines may induce immune activation, and that immune activation has been proposed in some cases to increase the risk for flare. But so I think that what we're trying to parallel here is that COVID vaccine has not been reported so far to also cause induced flare in our patients, even though there has been some patients, isolated cases reporting that they observed a flare after, but the overall numbers do not seem to be suggesting that, but we don't have that data yet. How are we doing with time, Sridhar? I think I've been way over, right?
You can continue. Keep going. That's okay.
All right. So just very briefly, this would be a topic for another talk by itself, just on the anti-rheumatic medications. This is not a comprehensive list, but I'm just going to highlight some that either were controversial or still are controversial. So just briefly on hydroxychloroquine, these are some of the meta-analysis studies looking at hydroxychloroquine. So either here on this A panel is looking just at mortality, and on the B panel we're looking at the composite of death and intubation. And so we really are not seeing as you can see, there is really no benefit of hydroxychloroquine here. And in reality, in this study here, there was an increase in mortality in hydroxychloroquine. And so, it's many of the, and these are mostly observational, but we had some of the different timing, and it hasn't really shown a benefit. Now, for anti-IL-1, there hasn't been many studies and just some cohort studies. And there were, when you look at the design, not a large number. So here 44 patients and here 16 patients. And then a lot of case reports. And they all seem to report a positive effect in terms of a decrease in intubation, decrease in death, and decrease in the amount of days of hospitalization. And so there was a lot of potential bias when you look at the design of this protocol still. So it's unclear. We don't really have a large randomized study. So this is just to show one slide here of one of the studies that we did at Bronx Care. And you remember I mentioned in the beginning about it was curious to notice that patients with gout seem to have a lower risk for developing COVID or being hospitalized. And so we were wondering what could that be? And there was some suggestion that colchicine, because of its inhibition of the cytokine inflammatory pathway, that perhaps if used early on, or patients who are on colchicine prophylaxis for gout, they could be protected from having the cytokine storm that one will observe in the progression of severity of COVID. And so what we end up doing was giving colchicine to, so it was an observational open label study, and we separated by floors in the hospital. And so one floor, every patient that would come, all patients are actually getting the standard of care. And so that can be a confounding issue as well. So they were getting steroids, they were getting remdesivir, they were getting tocilizumab. Many of these patients got tocilizumab, but then they would either get colchicine or not get colchicine. And so in our lower numbers here of patients, so in this group here calculated was 34 in the colchicine group and 78 in the control. We saw a significant improvement in terms of discharge, decreased death, so 47% versus 80% in the control, and also a decreased progression for intubation, 47% in the colchicine and 87% in the control. So there has been other studies of colchicine, also non-randomized, double-blind. However, they're kind of similar to our studies. We also look at some inflammatory markers that showed also a decrease in inflammatory markers. So there has been a couple of studies that suggest that colchicine could be helpful, but we don't really have large data to support that. So in terms of glucocorticoids, there is a lot of data. And when you look in here, all these different studies, many of them have a high potential for bias, and the effect goes from positive effect to negative effect. So the data is also all over the place. And perhaps we mostly look at the data that came from the UK as well, looking at the dexamethasone study. So that was the New England Journal publication. And that really shows an improvement of dexamethasone 6 milligrams for 10 days in terms of mortality compared to the standard of care, decrease in intubation, and also use of oxygen. However, the difference seemed to be smaller when patients were not on oxygen. And so that's like showed in here. So patients who were on ventilation or that were receiving supplemental oxygen, they seem to fare better on the dexamethasone. However, the patients that were admitted but were not on oxygen, they didn't seem to have that response and benefit of the dexamethasone. Now, the tocilizumab data also has been very prolific. We've seen lots of cohort studies, case series studies. As you can see from here, high potential for bias, and also with an effect that was mostly positive, but some were controversial, as seen in these two studies here. And then we had some large randomized control studies. And so one of the first ones was from Boston, looking at 161 patients with tocilizumab. And as you can see, when looking at mechanical ventilation or death, And the ordinal scale or the discontinuation of supplemental oxygen, there was really no difference between the two groups. And then we had the data from the IMPACTA global trial these are looking at patients a little bit earlier in their disease presentation, but also requiring oxygen supplementation. And in this case, they had a significant difference looking at 28 days after admission. And this was including 249 patients. And then we also have in this other trial was a global trial that included 294 patients. They also see a difference in this improvement of ordinal scale and hospital discharge. It's just that some of these were not powered to really look at mortality. And so there was always a question that, we are looking at some numbers that are improvement, but the mortality numbers did not seem to have reached a statistical significance. And then the data on the tyrosine kinase inhibitor, tofacitinib. I'm not showing the baricitinib, but also seem to be similar in terms that 154 patients treated with tofacitinib, this was published recently, showed improvement in this patient here for the primary outcome, which was death or respiratory failure. And to finish it, so there is we have been involved in a study in a collaboration with Pfizer. So Pfizer has a drug target of IRAK4 inhibition. And this is just to demonstrate here where is IRAK4 and how does it play a role in inflammation. So it can be really a downstream activator of a lot of different signal, and can be from LPS or IL-1 driven bacterial viruses, can all induce an activation of IRAK4, which will by itself increase downstream IL-6, TNF, interferon, IL-1, IL-10. And so this is an interesting target, and perhaps it's a little more downstream than the tyrosine kinases, and also a little more focused. And so it became of interest because this inhibitor is not available commercially. It has been studied in rheumatoid arthritis and had a positive, it showed a benefit in rheumatoid arthritis. And so we became interested, and this was early in March, we became interested in starting a collaboration with Pfizer and trying to bring this on a COVID trial. And so we do have currently a trial going on. As we learned, it's very difficult to have the study taken off because of a lot of regulations from the FDA. So we needed to get FDA approval, and so many steps. And by the time that we had it fully operational, our numbers had significantly gone down. So far we have recruited 12 patients, and the study is ongoing. The goal was to achieve between 60 and 70 patients for looking at some of the outcome to be significant. So we'll see. We're very interested, and this is on patients who are admitted with requiring oxygen, but not at risk of intubation yet. So it's an early stage of the disease. But we also have a second arm of the study that will include patients that are on ventilators. And that second arm is doing a collaboration with Yale, that they are also doing that. But as far as this arm, including these patients, we are the only ones that actually have this trial now. And this is another, so looking at, I forgot to mention that the vaccine and the response in our rheumatological patients, we actually do have a study that was NIH sponsored that has just been approved. We're waiting for an IRB approval. And so we are looking at all our rheumatological patients that were vaccinated. And what we are looking is patients who had a titer of lower than a certain threshold. In our case here is 50. We will be offering them a third booster, so a third dose. And we're hoping to start enrolling patients next month. So that's also very exciting because we don't know, and even in the general population, what a boost is going to do. But also we are looking at what might that do for our rheumatological patients with lower titers. So in summary, the age and comorbidities have a big impact, maybe much more than what our specific diagnoses are. Some medications, they don't seem to have, most of the medications don't seem to affect much the outcome of patients with COVID. However, we would watch out really more for rituximab. Also watch out for disease activity in terms of risk for COVID progression. And also RA may suggest that they have a little poor outcome, but it's still, I would go back here to the comorbidities. They have a much more stronger impact. And the response to the vaccines seem to be overall reduced in our patients. But you know, there's still more data to come. I have been looking at my patients, and this is just anecdotally. A lot of my patients seem to have good titers, but we really have to wait and see what the studies come back with. So that's pretty much all of it. Thank you very much, and happy to answer any questions.
Yeah, I think we'll start with the question in the chat box, and then I'll ask people to directly ask. So some of the patients who got vaccine had a flare-up of their joints and with rashes. What's your experience with mRNAs giving patients with rheumatological illnesses? If you gave vaccines, what happened to them? Did you mentioned briefly about flare-ups? Can you comment more about that?
Yeah, so there, anecdotally for my patients, I haven't really seen anyone with proven flare or reaction. And I question in that case if something was related to another component of an allergic reaction to the vaccine or even something else not related to the vaccine. And so, so we really don't have data on the COVID vaccine and inducing a flare. We don't think it's going to be high, and some of the preliminary data that I asked them from the registry, doesn't seem to be a signal coming up. But of course, there are exceptions, right? And so then we think that the same way in the case of the zoster vaccine, it was perhaps a 3 to 4% rate of flares. And these were patients calling up the nurse, and it's not really documented how exactly was the flare. But some of these cases, they were treated with short taper of steroids for a week or 10 days, and they seem to have all done well.
So when you're talking about steroids interfering, what's the dose are you looking at? Use prednisone as the medication. What's the dose where you begin to get worried that the vaccine may be not so functional?
Yeah, so the problem with that is that they were not really giving the breakdown on the dose of the prednisone, but we're really thinking that 10 milligrams is kind of like the amount of prednisone that will start interfering more as well. So if a patient is chronically on steroids, but it might be okay if they are on 5 or less.
And when you're monitoring your patients for antibody responses after vaccine, what's the longest you've seen persistence of antibodies?
So some of our patients really got vaccinated early on. So like in January, February, they started getting vaccines because they qualified. And for some of those patients, I'm still seeing, so I'm getting titers almost 6 months later now, 5 to 6 months, and I'm seeing that they have good titers. But it's problem like recall bias, right? So I might be recalling, the ones that I'm excited about. I was like, oh, great, like they still have good titers, and I'm forgetting about or the ones that didn't have. So it's a problem. But I have seen them with sustainable good titers 5 months later. But that's kind of like at most, I think, as I've seen 5 months.
5 months. Okay. All right. Anyone want to ask questions? Go ahead and unmute yourself.
Sir,
Go ahead,
hello everyone, sir.
Go ahead.
Sir, yesterday, I think 1 to 2 days back, CDC released a fresh document about this universal masking and revising masking guidelines. Even Israelis, they released latest position on the Pfizer vaccine. I just, in a flash, read in the news that the first dose produces only 34% antibodies and protection, and second dose produces only 43% odd. I just read in a flash, sir, and next I couldn't find any data, any information on that, sir. Pfizer first dose produces only 34% antibodies protection, and second dose produces only 40. I just read in a flash in the news, sir, but I couldn't get further information.
Yeah.
Did you come across, sir, any such news? Is it true, sir, actually?
I don't think that's low numbers were not reported in the US. It is true after the first dose, there's some said about 50% of people have antibodies, but low of 40% after the second dose, I don't think that's been reported in regular population. Maybe the immune suppressed ones, yes, right, Giovanni? I mean, people who took rituximab, drugs like that, don't you expect to see low vaccine? I think even the transplant population, they saw a substantial lower number of
Yes, sir. Yes, sir. I didn't go through the full news, sir. I just read in a flash. Is it in only immunosuppressed population, sir?
Yeah.
Okay,
Yeah,
sir.
I think so. Not in the general population.
34, 43, something I read, sir. Maybe they're apprehensive and they're going for a third or a booster dose. Even Israeli Prime Minister also given third dose yesterday, the booster dose yesterday, sir.
Yeah.
Okay, sir.
Go ahead, Giovanni. You talked about third dose. What's your opinion about third doses and boosters at this point?
I mean, we don't seem so. First, we think it's safe, right? And we're not seeing any problem with safety. And then we are not seeing a lot of, you brought the first question, like what if we have having flares? So we don't seem to be seeing a large number of. There's no signal of flares, and so I think it will. We don't know. I mean, yes, ideally. Is that a linear response? So after the first and the second in our immunosuppressed patients, how much are you able to increase that response? So are they able to change the adjuvant? And then also, are you able to mix? So if you got 2 Pfizers, what if you use a third Moderna? Like, would that give it like a different kind of response? So I mean, these are all unanswered questions, but I think that we all, we have to do the trials. And part of it is like, this is the one that we are trying to do is, yes, to do that third booster and see what kind of response we get. And for example, some of the patients that after 2 doses of Pfizer, they had really a minimal spike protein. And these were patients that were on methotrexate and in triple combination. So they were on an anti-TNF, which, as I showed, did not seem to have an effect. But they're also on methotrexate, and then they're also on sulfasalazine. And so are we able to stop some of those and so stop the methotrexate and keep just the biologic? So the problem is that there are so many different combinations when we're dealing with this. But I am optimistic that, perhaps giving boosters will actually increase their antibody level.
Yeah, that's true. Just to set it up before I take the next question, I just want to give you an overview of what's happening in the United States with the Delta variant in full swing in the United States. It now is nearly 90% of all infections in the United States are Delta, number one. From only a few weeks ago, we had fewer than 5,000 to 6,000 infections a day. We have now reached 80,000 infections a day now. So our third wave, or if you want to call it a wave, is already here. It's predominantly in states where the vaccine rates are less than 50%. which is how I think India would be when the third wave were to happen. I hope it'll never happen in India. So your vaccine rates are going up. So you would be looking very similar to how United States would look when that wave would come. So the other things that we've noticed is the vaccine still appears to be very effective. Most people who were fully vaccinated did not get severe infections, although there are breakthrough infections where some individuals did get quite sick and got hospitalized, and even deaths have happened. By and large, they were mostly older people or people with immune defects, like patients with HIV or patients who are immunosuppressed drugs. Perhaps in them, the vaccine is not as effective as it should be. And as in India, we've also seen that the disease has shifted to a younger population. That may be because there are less of them vaccinated. I think the United States did much better with older population vaccinations and has not been that successful with the younger population. So that's why the infection rates are higher. We're beginning to observe that Delta is actually more virulent than the other strains that we have. This is already confirmed in UK as well as in Singapore, and we know the experience in India. It was far worse than the original strain. What was surprising is the number of people who vaccinated who don't seem to have infection but seem to spread infection. So they are asymptomatic, positive, and that number is kind of quite surprising, that the numbers we are seeing, I think they're now counting more than 30,000 or 35,000 or so of them. In one large outbreak in Massachusetts, 75% of those who were infected actually had been fully vaccinated. Although none of them were seriously ill, but they did get infected. So when you're in a population where half the population gets vaccinated, and the other half doesn't get vaccinated, the vaccinated individuals are not really giving any protection to the other groups because the virus spreads through them. So, so total vaccination is the goal. Achieving 40–50% vaccination rates will not end this pandemic. So I think that's what India should prepare for. I think if what has happened in the United States were to happen in India when it comes around, I think more vaccines, and perhaps the mistake we made is to end masks rather early without having enough data was probably a mistake by the CDC. They've quickly corrected it, but I think they may have damaged their credibility a little bit in the process. But it goes without saying that masks are necessary and vaccines are still effective, but we need to push it as much as we can. We have not done so well in the United States, better than other countries, but this is the future that India should look forward to, vaccinating more people, I think. I think Dr. Apparao had a question. If you go ahead and unmute your microphone and ask.
Good morning, Dr. Sridhar. I just want to know whether COVID-19 will activate rheumatoid disease, rheumatoid arthritis, or gout. And I also want to know whether rheumatoid arthritis and gout can coexist.
So go ahead, Giovanni.
Yeah, so I think that there is a, when I was a fellow, my attending used to say that there was something that used to be taught for a long time, is that you do not get gout and rheumatoid arthritis. And so you should always think which one is the culprit. However, I have seen rarely a couple of cases that had a definite diagnosis of gout and also a definite diagnosis of RA. And so I think it's possible to coexist, but yes, it's not very common. Now, yeah.
What does COVID do to these various rheumatological illnesses? Does it make it worse? Does it make it flare up? Take one at a time, rheumatoid arthritis, and then gout. What does COVID do to them?
Yeah, so we really have not seen a major flares in patients that get infected with COVID. And so I think that in general, the patients, the mortality seems to be fairly similar and as the general population. And also the medications that they're on doesn't seem to make a lot of difference, except like I mentioned earlier, the rituximab and even the prednisone that patients that we are worried about. And when they broke down in different subgroups, that it seems really that it was patients who had a higher disease activity, they seem to be at a higher risk, not so much in terms of the prednisone itself. Even though we assume that prednisone over 10 milligrams has been showing a signal of a bad prognosis, but for when you break down in terms of how severe their baseline disease is, that seems to have a higher effect than the prednisone alone. And so I think overall, we are not seeing that COVID is making their disease any worse, because a lot of times one of the medications are continued in the background, or either they get some steroids as part of their treatment if they are progressing. But if they are not very symptomatic, we're not stopping their medications. We are continuing their immunosuppressive medication.
If a person has gout, now that you showed the benefits of having colchicine, would this prompt you to initiate therapy or keep them on maintenance therapy or anything like that?
So for sure, the patients that are on prophylactic therapy, I would advise them to continue on their prophylactic therapy. I don't think there is any downside of continuing during COVID. Perhaps there's even a benefit of them continuing that. But if they're having an attack and they are not on colchicine, I mean, colchicine is one of the treatments for acute gout, independent whether they are hyperuricemic or not. So I think that's a good option, perhaps better option than using non-steroidals or steroids. And so I would definitely move colchicine as my primary drug to go during an acute attack if they are not on colchicine.
Yes, Sudhakar, you have any questions?
Yeah. Dr. Franchin, you must have heard that the zero surveillance is taking place in India. Do you think it correlates with the clinical infection of the COVID-19? Has anything of that sort been done in the United States? Number one. Number two, what about the chances of people getting COVID-19 infection in those people who do not have adequate antibodies? It's a common practice for some of the people to go for the antibody titers after the shot, and many people will have a very few antibody titers. Would that is an alarming indicator that they're likely to get infected even after the vaccination?
Yeah, so there was a study that was just published recently looking at the titers and the surveillance, and it really seems to correlate with disease, with infection, and also disease progression. So the lower your titer does correlate with actually having worse disease. And I think it's being reproduced in other parts of the world as well. So in the UK and Israel and us, I think that, and even when they look at other variants for different vaccines. So for the Delta, they're seeing that seems to be the case as well. So I think, yes, that it does correlate. There's not really any guidelines to be testing all our patients for their titers. I don't think that primary care is doing that for all patients. I think that people are picking and choosing who they are testing, and perhaps patients with a higher risk. So when we look at comorbidities, so patients that have diabetes, that have obesity, hypertension, and chronic pulmonary disease and they are older. So I think that they, and this I'm speaking for myself, maybe I think that I would be looking at titers in those patients at a higher risk. I am doing for most of my patients just because of that question that I brought up, and that we all think that immunosuppression is making our patients less likely to respond to this vaccine. So I'm checking, and also in order to even offer them the possibility to participate in this study, that we'll be offering them a third booster if they are lower levels. But in general, I think that if I was looking at patients that are not immunosuppressed, I might be offering to check the titers if they are falling into the group with a higher risk.
Yeah.
What about that serosurveillance? Would it be protective? 70% of the people having the antibodies amongst the general population, do you think that it would be protective? And can that avert the third wave appearing?
Yeah, so but you were asking if you do a surveillance, so patients who do have titers that were exposed to the actual infection, whether you are offering them the vaccine or just making a choice of then putting them in the back burner, and no, that was not what you were asking.
No, it's basically this the general surveillance of the antibodies amongst the population, whether or not they have taken the vaccine. And particularly so in those people who have not taken vaccine, and if still they have the antibodies, would they be protected? And if you have 70% of them in the general population having antibodies, would that be protective and avert the third wave appearing?
So I think that Siddhar can help you with that too, but I think that the data suggests that yes, if you are doing the surveillance and if you're reaching over that 70% mark, that you are at a better stage in terms of averting the wave. But then, you know, just like Siddhar mentioned too, with the mask wearing and that, and then you have these people that are contracting mild disease and it's spreading to the other 30 to 40%. That are not protected, and so I think it has to be both, right? And so we have to be all having measurable titers, and either whether if it was natural infection or vaccine, and be wearing masks too.
So let me go back to the earlier part of the people and testing for antibodies. I've asked my own department, all healthcare workers who are vaccinated by and large, that they do test them, get their spike antibody measured. I wrote to all of them. I personally measure my antibodies regularly, and I've asked all healthcare workers in my department to get their spike antibody tests done and ensure that they had adequate titers. It's based on an Israeli study where they actually took these titers before, after, and also seen how many of them got reinfected, or had breakthrough infection. And it became clear that those who had low titers are more likely to get infected. But fortunately, none of them had serious infection. But there's one unfortunate thing that they observed was that those who had low titers could not resolve their symptoms rapidly. So in other words, their symptoms, if they had symptoms, persisted for more than 6 weeks. So they had prolonged phase of symptoms of COVID if their titers were low. And these are individuals who were never infected before. So I think that bothers me, and those of us who are constantly exposed to COVID, we should know our antibodies, I think, right now. The second thing that why I chose to tell my team to get tested is that we've seen the viral loads of Delta in this time around. They're much higher than the previous infections that we had. We do cycle threshold on every test that we do, and the thresholds are very, very low. So they're very high titers. And the CDC released their data showing, that's national, that those who were vaccinated and got infected had very high titers. So fortunately, they didn't get sick, but they had very high titers. And we don't know what that means in the long run. I think more information we have to we have to wait and watch. Now, the last question about you saying, well, 70% of them had antibodies, will that protect them? It's been shown from other data that infection-mediated antibodies are not as good as vaccine-mediated antibodies. The vaccine-mediated antibodies consistently were superior, and infection-mediated antibodies sometimes actually activated macrophages. So that's not necessarily a good thing to happen. So I wouldn't use that antibody as basis of not vaccinating. Will they be protected? That's a hope, but there's no evidence that really protects. I mean, herd immunity, there are many virologists who believe that COVID will never be a herd immunity for COVID. That will never happen. We'll just have to deal with better vaccines and eradicate it that way. It won't go away because of herd immunity, because the virus mutates so much in its spike protein, it'll evade all natural.
You're not audible. You're not audible, Sridhar. You're not audible, Sridhar. I think your microphone went off.
We can't hear.
Sridhar.
You can't hear me?
Yeah. I mean,
can you hear you now? There's a comment in the chat window saying that your name is similar to a famous soccer player in Uruguay. I don't think you'd be happy to hear that, because you're Brazilian and you're a staunch supporter of the Brazilian soccer team, right? You want to comment about that?
Sridhar, there's a question from me. Hello.
Yeah, go ahead, GSR.
Hi, Sridhar.
Yeah, go ahead.
How are you? Yeah.
Good.
See, regarding remdesivir, people have used remdesivir in the second week when the patient has become sick and then he is on ventilator. It's an antiviral drug. And this is, I think it has to be given when the patient is having fever third or fourth day, when the viral replication is maximum. I don't know why that study is not done. Because we are, by giving drug, when they burnt out phase, I don't think it is going to be effective. Probably there should be a study wherein if the patient continues to have fever on third or fourth day, they should be started on remdesivir before they get into complications, hypoxia and all. What do you think? Should we have there should be a study like that, or just leave it like that?
We have studies with monoclonal antibodies in that regard. So we take patients who have risk factors and give them monoclonal antibodies, not remdesivir. We give them as early as we can, as soon as we identify patients, and we give them, and they're highly effective when you give them there, because these antibodies basically neutralize the virus and prevent worsening of illness, prevent admissions, and prevent death, actually. Giovanni, you used monoclonal antibodies in patients with rheumatological illnesses. You want to comment on that? And then I'll come to why not do a remdesivir study.
Yes, so we actually had a few patients. Perhaps we had like 4 patients that had rheumatological disease in the background, and the concern again of using these is whether it would activate their disease. And in these cases, we hadn't seen any disease activation. And they did as well as patients without rheumatological disease with the monoclonal antibodies.
Yeah. Now, the study about remdesivir, doing it early, the problem is that a vast number of patients still do very well with COVID. They're not going to get sick. They won't end up in a hospital. It's a small percentage of people who will end up in a hospital. So
I think what I'm asking is, see, most of them who have fever for a day or two, and then that the group is fine. But those people are continue to be toxic and having fever for third or fourth day, then these people are likely to go into problems in the second week. So for that group of patients, I think some of the doctors here, they start to speak for us, and most of them they could prevent. I think that study should be done because we should not blame remdesivir. Remdesivir should be out if it is really active against viral replication.
I think one of the original studies did start.
For sick patients.
No. One of the original studies, they did start the remdesivir early, and that's the one that showed. One of them showed a reduction in hospitalization, duration of stay in the hospital. So far, none of them showed a decrease in mortality because it's not a highly efficacious antiviral drug. It's modestly efficacious. So it will probably not show a big difference whether you started early or late, I think. This is the best we'll get out of remdesivir right now. I don't think it is the antiviral drug that's going to change everything. I think newer drugs are being developed. I think hopefully they will be more effective than remdesivir. There is a couple of two pills. One is both are oral medications being developed by the NIH, which is showing a lot of promise. Hopefully that will come into clinical medicine soon.
Hello, Dr. Sridhar, can I speak?
Third wave is on in India.
Hello?
Yeah, third wave is on in India now because the only state which is showing more statistics, I think, is Kerala. So Kerala, it continues to increase, and the rest of the states that is decreasing, they are showing less numbers. Probably
okay.
The numbers are more.
Yeah,
Dr. Sridhar, can I go ahead? Good morning. I'm Dr. Naveen. Dr. Givani, that was a very good lecture. I just want to know what is your protocol regarding the DMRDs, patients who are on DMRDs and vaccines. Like there are a number of drugs like methotrexate, mycophenolate, sulfasalazine, and leflunomide, and low-dose prednisolone or deflazacort. So what is the protocol for these patients when they go in for vaccination in the US?
Yeah, so maybe I'll, do you want to see that table that I had from ACR? So ACR.
Yeah, but it was a little confusing. Yeah.
Yeah, so I'll put that table.
So
again.
Usually you continue all the. Yeah, usually do you continue all the multiple DMARDs or you try to reduce them? And do you advocate stoppage for 2 weeks prior to vaccination and go ahead, or just continue everything?
So in general, I continue everything, and it's just here. So in general, I continue everything, and so this table, they made it easy. Really, methotrexate is the only one that they recommend to hold a week after the vaccine, as well as the JAK inhibitors. Now, for abatacept, they say a week before and a week after. And cyclophosphamide IV, which we don't use as frequently, 1 week after. And rituximab, 4 weeks before to dose the rituximab. So for everything else, no change. You can continue everything, the steroids, everything. Now, I do not stop methotrexate for all my patients. If that's the only medication they are on, for their rheumatoid arthritis or for their lupus arthritis, and they have a history of flare up when they stop the medication, I don't tell them to hold. I tell them to continue it, because I think that the risk of flaring might be higher, a higher risk than just giving them a better option to mount a good response to the vaccine.
Thank you.
Okay. Any other question?
Sridhar, can I?
Yeah, go ahead, Vidraj.
Thank you, Sridhar. I wanted to reply to Dr. Sudhakar's query about the recent sero survey. So the ICMR came out with their 4th sero survey. The last one, the 3rd one, was in December of last year. And in fact, that survey had shown kind of similar results, about, I think, in the range of 50–60% in terms of seropositivity, both from vaccine and infection-related serology. And we know what happened in April, May this year after that sero survey. So there's several flaws with that sero survey. One is it was a very small sample size for a country of 1.4 billion. So the sample size was somewhere between 28 and 30,000. It wasn't really representative of the population, even with that low sample size. If you notice, there were, out of the 29 or 30,000, 7,000 of them were healthcare workers. And the entire 30,000 was basically distributed over 70 districts across the country. And so each state wouldn't have had a sample size of more than a few hundred, or, at the max 1,000. So I would take that data with a pinch of salt. Certainly that cannot be extrapolated to a population of 1.4 billion. I mean, I'm not a statistician, but I think that's very obvious. I would be very wary of interpreting that data, because I think we have precedents for that in December, and the country was totally caught off guard, thinking that significant population was immune to the disease, number one. Number two, the correlation between serology and the lethality, morbidity, and infectious capabilities of the disease, I don't think we have enough data for that, especially with Delta strain. I think that becomes an issue, because we're seeing more breakthrough infections. We're certainly seeing a lot more lethality and morbidity, I think, with Delta strain in the Western countries now. And I think the experience in India is a big lesson to the rest of the world, not to depend. Like you said, I don't think we're ever going to achieve herd immunity. There's always going to be immune escape. The only way, this pandemic might die down to reasonable levels is with loss of function rather than new mutants with gain of function. I think there's been sero surveys in other countries as well, including Pfizer. I think the US has done limited sero surveys, but they haven't really paid much credence or used that data to dictate policy. And that's what I've been suggesting here too. Don't go by that sero survey data, because one is it's not adequately powered. Number two, it doesn't represent the population. So the population of healthcare workers, for example, in India is less than 1%. The survey included 7,000, so more than 25% of the sample was actually healthcare workers. So I would be very wary. I think that should answer Dr. Sudhakar's question.
Yeah. I mean, we did the sero surveys in the Bronx, and the antibody prevalence rates and infection didn't match at all. I don't think they're useful at all. What matches is the vaccination rate. I think higher the vaccination rates, lower the serious illness, and lower the rate of infections. That's widely in the United States. We could see it. States which had lower vaccination rates have substantially higher infection rates. States with very high vaccination rates, like New York, our numbers are not still very high, even though we are kind of quite worried about the rates that we're seeing. We caught up to 2.5% positive rate from a low of 0.4% in a matter of few weeks. There are parts of New York State which have now hit 4.5%. But again, where the vaccine rates were low, we have a higher infection rate. So I think vaccine is the key. It's not serosurveillance studies.
Yeah, we're seeing that in Nebraska and Iowa now. The numbers are rapidly rising, mostly in unvaccinated people, but there's a significant number of vaccinated people getting breakthrough infections, fortunately with not so severe illness. But like in India, in Nebraska and Iowa, I'm hearing now that we're seeing younger people getting more sick in their 30s and 40s. So I think, I should thank people in India for sharing all their experiences, because this is, I think, going to help us actually.
Yeah. We've seen fully vaccinated people ended up in our ICU. We've seen 2 severe infections. Fortunately, both have survived so far, but they ended up in the ICU. One even ended up on a ventilator, fully vaccinated. Out of the 2, one had absolutely no risk factors at all. A 39-year-old, otherwise healthy, got Janssen vaccine, and subsequently traveled to Mexico, came back. We assume most likely had a Delta variant, end up with severe bilateral pneumonia. Likewise, we've seen 2 other individuals fully vaccinated. One was HIV positive, so we could understand that. What is shocking now is we have a 50 or so year old obese person who we actually have his spike antibodies, which are substantially high, and still ended up with severe bilateral pneumonia. So breakthrough infections are inevitable. And I think that's any virus, any vaccines will do that. But I think
2 doctors and 1 scientist, I think, that came to India after receiving Pfizer vaccine, and they succumbed to infection. I think that fact is known to you, Sridhar.
Pardon me?
So 2 doctors who came from US to see their parents who are sick. Who already received Pfizer vaccine, and 1 scientist known to my brother who is there, they died.
I think vaccine failures will happen.
Infection in India.
Yeah. I think that's why you should vaccinate and you should wear a mask. I don't think you should drop your mask anytime soon. Vaccinate and wear your masks, especially when you're indoor crowds. I think outdoor probably safer, but indoor, I think the CDC made a mistake. So they're quickly changing their guidelines to put masks back. I wouldn't be surprised that they will enhance the type of masks also. I think more data is showing that cloth masks are not so great, that the surgical masks and K95s and even N95s may become the recommendation. I wouldn't be surprised. With such high viral loads, I can't imagine a cloth mask protecting us. So I think we'll soon move to surgical masks and maybe KN95 masks and even N95 masks for the general population. I wouldn't be surprised if we go there.
Yeah.
How long is this?
Yeah.
Any comments?
Yeah. One question, Sridhar, here.
Yeah.
Now that we have come to a conclusion that the antibody titers are correlating with the clinical infection. So now after the vaccination, now that can we recommend 1 more dose for those healthcare workers who do not have adequate number of antibodies, because the low titers are always correlating with the enhanced disease pattern in them. Would that be a recommendation to come up soon?
I think right now we can't say it. The CDC is looking at that data. The Israelis have data which supports that notion, and that's why the Israelis went with the 3rd dose. United States is more skeptical about that approach. But I think I wouldn't be surprised if booster doses are on the way. I would not be surprised that they are on the way. I think people with low titers, the CDC will probably change because we were lulled into this belief that, oh, don't worry, T cells will be there. But now they're seeing the breakthrough infections at numbers that are quite impressive, that the CDC might say people with low titers should get a booster dose. What's not clear is which is the booster dose you want. I think Giovanni pointed out something interesting, that the adjuvant that they use for vaccines is different based on different vaccines. And in fact, one of the vaccines that is about to be approved in India, the Novavax, has a quite different adjuvant, and they believe that adjuvant is quite potent. And maybe the third dose would be a different vaccine. I think that study is being done in France, and we should wait until that data comes before we commit ourselves to booster dose. But I think that information is not too far away. I think we probably in a month this will change, and I think there will be better guidelines on who should get a booster and what should be the booster.
Maybe like what we were saying before, the tourism agency and the airlines might push, because now they're almost, you know, if you're 6 months out of your vaccine, they're almost consider you as a virgin vaccinated again. You know, like your clock went back to zero. So maybe they're going to be pushing for this.
Yeah. So we do get a lot of tourists from Asia who are now getting mRNA vaccines after they got the Covaxin or the AstraZeneca vaccine in Asia. They're coming to the United States and getting 2 doses of mRNA vaccine, and they're doing quite well with the vaccine. It remains to be seen how many of them will end up with an infection. So we're watching them. We have a few dozen of those who got vaccinated elsewhere and now gotten mRNA vaccines, and we're watching them.
Yeah. Sridhar, how frequently are you getting your healthcare workers test their antibodies?
Actually, we just told them now. My goal is to get it done every 6 weeks.
Okay.
Yeah.
So Sudhakar Garu, at University of Nebraska, and at least in the Midwest, our medical school hasn't even started thinking about a policy of checking antibody titers in staff. So if Sridhar is doing it, I would like to have that data and what protocols you have, so I can suggest at least to our division that maybe we should start checking, because I think we were lucky the last 6 months not losing any of our faculty or healthcare workers. But with Delta strain, there is some real concern that it might change.
Yeah, I don't have any data supporting what I'm doing. You know, I've been doing this leadership, is some of it is instinctive, and some of it is gain experience after you do that data. So the data you ask for, we'll collect it and see what it's showing. So yeah, the high viral load really concerns me. I think that's when I saw, we gathered the data and saw that there was a significant change in several weeks that we followed. And that's when I told all my staff, please get spike antibodies done. Let's see what it shows. Several of them have done, and they seem to have fairly high titers. Some of us, actually, our titers have gone up. So I got vaccinated in January. But I'm constantly exposed to COVID because I do monoclonal infusions with them. But for whatever it is, my titers have actually gone up since then. So from January to June, my titers went from, I think, 250 to about 1200, like that. So the titers actually gone up many months after the vaccine was given. The only explanation is that I was exposed to virus, so the immune system kicked in. Okay, I think that's all we have. Sudhakar, anything else? And otherwise, you can do it yourself.
Yeah. Thank you very much, Sridhar, for that wonderful discussion and moderating the session so effectively. The final word from Ram Mohan, are you there? Do you have anything to say?